Thank you all and welcome this morning to our Motivational Interviewing for Tobacco Cessation Use in the Lung Cancer Screening Context webinar. I'm Angela Criswell with GoTo Foundation for Lung Cancer. I'm the Associate Director for Quality Screening and Program Initiatives. So glad to be with you all today. We do have a few members of our team who are also here. Robin Mohan, who is our Coordinator for Excellence in Screening and Care. Anita McLaughlin, who's our Director for Economics and Regulatory Policy. I think many of you have probably interacted with her. There are additional members of our team who I think many of you have probably interacted with that are out in the audience. Leah Fine, our Senior Director for Excellence in Screening and Care. Kim Parham, Associate Director for Quality Care and Clinical Relations. You'll probably know her. Those of you who have our Care Continuum Center of Excellence designation have communicated with her, no doubt, to a great extent. Maureen Rigney is our Director of Support Initiatives, and Kathy Levy is the manager of our ALCASE project, which stands for Alabama Lung Cancer Awareness Screening and Education Project. Please feel free to call upon any of us at any time when we can be of assistance to you all. At the end, I am going to share an email address where you can reach us, and from that email address, we can navigate you to any of our staff who can be of assistance. There have been many exciting developments in lung cancer screening recently, of course, with yesterday's new final recommendation coming out from the U.S. Preventive Services Task Force that expands screening access to so many more people. Please stay tuned from us because we will be sharing out more resources and more information, including work that's underway to request coverage for this new population from CMS. That will take some time, but we will try to make sure everyone is kept in the loop on that work as well. This afternoon, I will share a link to an evaluation for this webinar. Please use that opportunity to let us know of any other topics that you'd like to see us address or presenters that you would like to hear from. Now, today's webinar is being recorded, and once the recording is finalized in a few days, it takes a little bit of time, we will put it up on the For Professionals section of the GoTo Foundation website. I'll send everyone a link to it. In the meantime, check out our prior webinar recordings if you haven't already seen them. We do invite your questions. Please submit them through the Q&A box. We'll hold them until the end of the presentation, and for any that we can't get to or that we're unable to adequately address today, we'll do our best to follow up and provide answers as soon as we can. I am so pleased to have with us today Dr. Rashelle Hayes. Dr. Hayes is Associate Professor in the Department of Psychiatry at Virginia Commonwealth University School of Medicine and is an Associate Member for Cancer Prevention and Control at Massey Cancer Center. There is so much to Dr. Hayes' rich background, but to share just a few highlights, her broad research and clinical interests are in cancer prevention and control, specifically in developing and implementing evidence-based tobacco smoking cessation interventions targeted to various medical populations, including those seeking lung cancer screening. She's also focused on the use of digital health interventions to facilitate behavioral change, implementing hospital-based tobacco treatment, and training of healthcare providers in behavioral health counseling, including the use of motivational interviewing, which is our topic today.
Hello there, and thank you so much for that lovely introduction. It is my honor and privilege to speak to you about this topic of motivational interviewing, tobacco treatment in a lung cancer screening, all areas of which are very important to me. I not only do research in this area, but also see patients myself treating tobacco dependence as well as within the lung cancer screening context. So the title of our talk today is Motivational Interviewing for Tobacco Cessation Use in Lung Cancer Screening. The only disclosure I have is an NCI grant that was funded to develop and implement tobacco treatment for our patients with cancer here at VCU School of Medicine. And I do not have any other commercial or speaker conflicts of interest other than that. So just to start off, let's just go over some of our learner objectives. The first is to describe the role of motivational interviewing in tobacco dependence treatment, then describe the essential elements of motivational interviewing spirit and guiding principles. Of course, next we will differentiate patient-centered counseling skills, or the OARs, which we'll talk about later, and also become familiar with MI-consistent strategies for smoking cessation. And then lastly, become familiar with MI-consistent tobacco treatment strategies targeted to the lung cancer screening population. So just to start off with some background, we all know that smoking and tobacco use contributes to more than the majority of death, particularly around lung, bronchus, and trachea disease and cancer. And we do know also, fortunately, that there is a huge benefit from quitting. When we can see here in this these slides here that when we talk about lung cancer mortality, having a CT scan does reduce mortality, but as well, smoking cessation does as well. And we can see that the longer that the person has smoked, that benefit of reducing risk of mortality increases. And the same thing is seen for total mortality. So given that, there is a rationale, right, for tobacco treatment at lung cancer screening. And some of the points here is that folks who are going through lung cancer screening, 50% in research has shown that they are current smokers. However, it's important to know that our guidelines for tobacco treatment also suggest to intervene with recent former smokers. We know too from the prior research that the interest in quitting is high but variable in the LDCT population. We know from the NLST study that in that group, 70% considered quitting, another 17% were preparing to quit, and only 13% had no intention to quit. So this is a captured audience who is somewhat primed to go ahead and want to try something or interested. Also, we know that the LDCT screening can be identified as a teachable moment for smoking cessation. And while the evidence varies, a majority of current smokers with lung cancer screening report an increase in motivation to quit at 6 months post-screening. There's also, along with that, no clear evidence that a negative scan or nothing found reduces motivation or smoking abstinence over time. Lastly, I want to say that cessation rates after just having a scan itself range from 12 to 42%, and that's just from having the scan itself. Thus, if we added smoking cessation intervention in the context of LDCT, we can assume can only amplify the benefit of having a lung cancer screen. So really the question is not whether we do this, but how do we provide cessation services in this setting? And folks are really interested in that. There's been a couple years now out trial or a group called the Smoking Cessation at Lung Examination, or the SCALE collaboration. And that's really 8 projects from different academic centers that are really aimed to ask, what are the key components and characteristics of effective smoking cessation intervention delivered in the lung cancer screening context or setting, and what are those implementation strategies that optimize integrating existing evidence-based smoking cessation interventions in the lung cancer screening. So those, the majority of those projects were funded in 2015, so we're all waiting to hear what are some of the outcomes from that. So just to let you all know, or just kind of review tobacco treatment best practice guidelines. It is best practice guidelines to identify, document, and treat every tobacco user, regardless of their motivation to quit. Also important to implement the 5 A's, which are brief, effective, evidence-based treatments. And we know that the greater intensity or duration of treatment suggests greater effectiveness of smoking cessation. It's also best practice to provide behavioral counseling, and that consists of problem solving, teaching coping skills, relapse prevention skills, as well as setting a quit date, making sure that the patient has a good support system, and as well, importantly, build motivation to quit or stay quit. Additionally, pharmacotherapy is extremely important. So that consists of nicotine replacement therapies, bupropion or varenicline. And then, of course, we know it's best practice, the longer or repeated contact with both behavioral counseling and pharmacotherapy is the best option. So this is from our tobacco treatment guidelines, just some data from that. And what we know is that For physicians and even non-physicians, the odds of helping someone quit smoking is much greater than if there was no clinician or if it was self-help. And so this is the odds ratio here. So we know that even if you're not a physician, or even physicians are going to increase just the amount of implementing the 5 A's is going to help the patient quit smoking. We also know from our guidelines that the longer a person interacts with the patient, the greater the odds of quitting. And so we can see that when you get to 4 to 30 minutes, we see a substantial increase in the odds of quitting compared to 1 to 3 or no minutes. And really, what we see here, 91 to 300 minutes, 31 to 90 minutes, really if we're doing something at 4 minutes minimum, we can see that increased odds there. And so I think that's why we have some of our billing guidelines to do at least 3 minutes of intervention with the patient. So important to keep in the back of our mind the importance of intervening at point of care. So I'm sure most of you have seen this diagram before about the 5 A's. Just to kind of review, we've got ask if about any tobacco use, not just smoking cigarettes, but any tobacco use. And even if they are not using, or if they've recently quit, we do want to assess for their confidence and motivation to stay quit. We do want to advise them to quit if they haven't already, and assess their willingness to make a quit attempt. Then if they are interested in quitting, we do want to assist them in that, suggest either referring them out to additional resources or provide some brief counseling and medication if appropriate. And then importantly, we do want to follow up with a follow-up appointment and arrange. So this was a study among NLST smokers, and I found it really, really interesting to see, because this is in a lung cancer screening context. And the important thing here is that we've got the 5 A's, and this study around 3,000 patients from the NLST study found that that the odds of quitting smoking are greater if the person also received the assist and arrange 5A. And the odds of quitting were not really that much different, even if they got the ask, advise, and assess. So it's really kind of hones down this importance of going ahead and assisting and arranging folks to help them. That's going to be associated with their ability to quit. And what's interesting too is that the rates of provider delivered 5 A's at 1-year follow-up, we see there's much less percentage of patients who have received assist or arrange. And I think the things that we're going to talk about here, motivational interviewing, can fall within the assist and assess. So we're probably wondering, like, where does motivational interviewing fit into the 5 A's? Well, it really fits into both, like I said, the assess part here, as well as the assist part here. And I personally would actually say that motivational interviewing or patient-centered counseling exists throughout the entire encounter, even at the ask and the arrange, and we're going to talk about some of that here. So that's why here on this slide I have patient-centered communication should be implemented throughout the encounter. It's important, if you don't know already, that motivational interviewing is a type of patient-centered communication style. All right, so let's get to learning about motivational interviewing, or MI. And as you learn or relearn this, I'd encourage you to think about what are your goals and what are your opportunities to practice MI, motivational interviewing, in your current workplace. So before we jump into the skills of motivational interviewing, I think it's important to understand behavior change and motivation. So I always just have this quote: you still need to floss your teeth more, And just think about, how does that sound? How do you react when someone tells you you still need to floss your teeth more? So really, let's talk about, how do people change? How do we get from behavior A to B? Is it because folks lack information regarding the benefits of flossing? Is it because it's difficult to acquire floss? Think about what's really missing. Well, some people would assume that it's knowledge or the floss, and that may be true, but what we know is that knowledge is usually not sufficient to motivate change. And instead, we do need motivation, and it's important to understand that motivation is dynamic and fluctuates. Oops. So we do need knowledge and motivation. And the thing about motivation is that there's this concept we call ambivalence, and that's where we feel two ways about something. It's important for us to understand that ambivalence is the norm. And why is that? Well, because change does take a long time. It is usually, when we're trying to change something, it's because it's a personal decision. But the biggest thing that we have to understand is that there are benefits to staying the same. There are benefits to continuing the behavior that we are doing. If you think about with smoking, there are benefits to smoking, the benefits from nicotine. So folks are going to feel two ways about a behavior. It's because there is a benefit to both. There's a benefit to the change, and there's a benefit to staying the same. So motivation then is not only internal, but we can change that motivation because it is also a product of the interaction between two people. Motivation is going to be very sensitive to the interpersonal interactions with influential others, such as peers and doctors and helping professions. We always say that an unmotivated patient is someone who doesn't know something, or we assume that there's something wrong with the patient, they don't know something, and there's nothing that we can do about it. But that's not true. There's very few people who are completely unmotivated when they're ambivalent about a decision. So our goal is to elicit their motivations for the change. So bottom line, as I just said, how do we help people change the behavior? Well, really, it's we have to think about how we talk with folks in order to influence their personal motivations. And our goal then, as a provider or family member, is to really guide that person's desire by evoking or eliciting their own desires, abilities, reasons, and need to change. So let's jump into motivational interviewing. What are the skills needed to learn this? Well, first, let's talk about what it is exactly. So here's our definition. Motivational interviewing is a patient-centered, collaborative, and goal-directed conversation style for strengthening a person's own motivation and commitment to change by resolving ambivalence, all during an atmosphere of acceptance and compassion. I've kind of highlighted the bold words here, and it's basically all of it. But everyone can take from this and see that as we are interacting with patients, we do want to make sure and be mindful that we're implementing all of these bolded constructs here. So what is motivational not? It's not a set of technical intervention, but it's really, actually, you could think of it as a way of being with the patient. And this way of being with the patient is often called the spirit of motivational interviewing and has 4 components. I would argue that it's very important, like I said, to be mindful that you are exercising your MI spirit, because that's really what's going to help drive your rapport with the person and develop that alliance with the patient, leading to behavior change. So what are the skills needed to do motivational interviewing? Well, you got to really know and practice your MI spirit skills. And then I also would argue that you have to be familiar with what we call the 4 fundamental processes and behavior change principles, as well as the 4 fundamental techniques. So we will go over those right now. So focused on the spirit of motivational interviewing, first fundamental approach is this concept of collaborating versus confronting with the person. You have to understand that when we're working with folks, it is a partnership, and that each person brings their own expertise and expectations. It is a shared, a shared power relationship where you both, the provider and the patient, are pursuing common goals. It does suggest a respect for one another, and it suggests that you as the clinician or clinician here is a facilitator, not telling someone what to do. The next fundamental approach is evocation versus education. So evocation means to evoke from, versus education where we're giving someone information. And this is under the understanding that the motivation for change really does reside within the patient. And it is our job to evoke their perceptions, goals, and values. In other words, their own expertise, what they know about their desires. The patient does most of the talking if we're evoking those things. And when we educate, we're assuming that they lack knowledge, insight, and skills for change. So that doesn't make you feel good if you're being told a lot of things that you may already know, right? And that's going to be resistant for behavior change. Okay, and the third fundamental approach is something we call autonomy versus authority. So this is where we definitely have to let it be known to the patient that the patient has their choice. It's their choice. It's their perspective. It's they have the ability to make decisions, and we should be at every single step of the way informing them of that choice. By doing that, it's going to allow the patient to feel empowered, and having that confidence and sense of empowerment is going to help lead to behavior change. Okay, so I always like to use this phrase PACE, which stands for the partnership, acceptance, compassion, and evocation. We have to practice all of those types of things. And if we are not, then we are not implementing MI spirit. So without PACE, there is no MI spirit. Okay, so moving on to the 4 fundamental processes. So these are really guiding processes that kind of are the stepping points in any type of encounter. So when you first meet a person, you are relationship building, you're engaging them, right? And so that may take 2 to 3 minutes. But then afterwards, you do want to focus on what is the topic and set the agenda, guide the conversation towards behavior change potentially. From that, you go on to evoking, and this is where a lot of motivational interviewing skills takes place, where you're highlighting what we call change talk, which I'll talk about later, and using a set of series of questions and skills, MI skills, to evoke change talk. And then once the person is ready to make a change, you may be in the planning stage, and smart goal setting is often used in the planning stage. So really important to kind of understand these processes and not try to jump ahead to planning when you haven't engaged the patient or focused on the conversation. Okay, now let's talk about some of the principles of patient-centered counseling. I know a lot of you will know this, but this is my take on it. I do think it's really important to set that baseline information of just how do you just be with a person. Patient. So first principle is about spirit. Spirit is everything. Motivational interviewing is about dancing, not wrestling with the person. It's about guiding, not directing them. Second principle is understand what I call a continuum of communication. So we have red, yellow, and green light, where red light, if you catch yourself doing any of these things, demanding, disapproving, disagreeing, disaffirming, we probably should not do that. And we want to have a red light there. That's very teacher or physician centered. when we're seeing ourselves that we're approving, advising, deflecting, or agreeing, that's not a bad thing. But again, it is physician-centered. So you want to proceed with caution and just make sure that the patient is not just yesing you to agree. We do want to be asking, affirming, reflecting, and summarizing. And that is very patient-centered, where the information is coming from the patient. And that's a green light, proceed. Okay, third principle, listen. So listening sounds easy, harder to do, but listening means being present, being patient, using all of your senses. So letting folks know that you're listening, nod your head, give encouragers, as I call it, be curious, don't interrupt, but be curious. Those are all great signs that you are letting your patient know that you are listening to them. There are roadblocks to active listening, and if you find yourself interpreting or giving advice, persuading, disagreeing, ordering, warning, probably not good signs, right? Very non-patient centered there. Okay, fourth guiding principle is to understand motivation. We kind of talked about that already, and the important thing is that for you to understand is that motivation is dynamic and fluctuates. You could be motivated today and not an hour later. It does come from the patient. You do have to kind of figure out and help the patient say what are their core values. We don't want to assume that health or health consequences is a reason to motivate the person. You want to explore what are their motivations. You do want to also, I think it's important here to not underestimate the positive aspects of the status quo, that there is a reason for ambivalence, quite normal. And if it's difficult for you to see, understand that you have to understand where the patient is coming from. So understanding motivation is really important. Okay, fifth principle, the writing reflex. So often, as educators, as physicians, we want to correct, we want to educate, we want to fix, and that's not usually helpful. And you do want to do those things, but be very strategic as to when you correct information. So be very strategic, find out what the patient knows already before just coming in and correcting that information. I think it's also important to ask permission before educating or informing, and I will teach us a little bit about a strategy, a skill set to do that. All right, sixth principle, support self-efficacy. Self-efficacy is really just means their confidence to do a specific behavior. And by doing this, you are acknowledging the patient's strengths, you're encouraging participation, you're sharing and decision-making. By supporting their confidence, you are sharing that you have hope and possibility for that person. A person's belief in the possibility of change is an important motivator. So we really have to let the patient know that, yes, you can do this, and here's why I know you can do this, and we are also here to help as well. Just want to say along with that it's really important for us as clinicians, as physicians, to believe in that patient's ability to make the behavior change. Often if we say, oh, they've been smoking for 50 years and they're never going to change, then unfortunately, we may be setting the patient up for that. And patients can really tell if we are really having some hope. So I really think that we have to be very understanding of what is it, why would we want to judge someone? And that's not very patient-centered, right? There is something called the Michelangelo belief. So when Michelangelo did his artwork, everyone and other people just saw like this piece of concrete, but he saw something different, right? So he saw something different from that concrete slab, and created beautiful work. And I think that we as clinicians also have to see that, to see the potential change in every person, no matter how long the behavior has been going on. Okay, seventh principle, acknowledge the patient's expertise. So, we don't want to be coming in and giving prescription values or teaching or telling people what their values are. When we do that, that's actually a deficit-based model. And instead, we want to come from a strength-based model where we're evoking or eliciting the patient's own knowledge, their values, their own pearls of wisdom, their expertise. So really important to be mindful that we want to work from a strength-based model. Eighth principle, express empathy. Empathy is understanding from the client's perspective, understanding not just what was said, but what was meant and not said. It does not necessarily mean that you feel what the patient feels or thinks, because that would be impossible. We are not that person. But it does mean that we do need to demonstrate an understanding of the patient's thoughts and feelings. And that's often done by reflecting what they've said. When we are able to show empathy, it does facilitate change. And patients will then have an increased opportunity to explore what is it that they want. And we have a better understanding of the patient because the patient is going to be more open to that conversation. In psychotherapy research, empathy and that relationship are two things that are probably the most predictive of successful mental health outcomes. So love this video by Brene Brown. If you have a chance, if you have not already, please do watch it. It's kind of funny and cute, but it's also important for us to understand this quote, patients don't care how much you know unless they know how much you care. So it's not about the knowledge we have as clinicians or educators, but it's really about how much we are demonstrating to them that we care. All right, ninth guiding principle, develop discrepancy. So motivation for change occurs when people perceive a discrepancy between what it is they want and where they want to be, or where they are and where they want to be. When the MI is conducted properly, the patient, not the clinician, voices the argument for change. So really kind of making the patient see that there's a gap between what is it they want and where they are. Okay, 10th principle, roll with resistance. Confrontation and persuasion are not effective. We do have to accept the patient's views, even if they're different from our own. Resistance is not directly opposed. We don't fight it. We instead what we call roll with it. And statements demonstrating resistance are not challenged. So always the patient is right, and take a step back and reflect. If we do come up with some resistance, then it's a signal for us to kind of examine our own behavior, and maybe not our behavior, but also our words. What are we saying? Am I advising or telling, educating when I haven't asked permission to do so yet? That could be a sign that may have contributed to some of that resistance. So markers of a productive encounter, when the patient's doing much of the talking and they feel listened to, when they continue to think or decide about the change, even if they're ambivalent and continue to be, it's a good thing for them to be ambivalent than to just say, nope, not going to do it. When they want to, when they request more information about change, and if you're following the patient over time, you'll see that you've had a productive encounter because there's going to be more commitment language within the visit and between visits. A couple other things here that they're going to be safer, feel safer with you, and may express some emotions with you during the visit. That's also a very good marker of a productive encounter. All right, so let's get into these MI techniques. We can go through these really quickly, but what we call the techniques are ORS, and they really stand for open-ended questions, affirmation statements, reflective listening statements, and summary statements. Really important to understand that 3 of these things are statements and only 1 are questions, open-ended questions. So let's start with open-ended questions. So it's really great to kind of kind of build up your skill to kind of convert in a yes/no question to an open-ended question. So for example, if you have, do you want to quit smoking? Think about what are some other ways that I can make that open-ended. Remember, if you're asking an open-ended question, it's going to make the patient talk more. And that's what we really want to do. We want them to be able to explain and elicit. We are eliciting from them their thoughts and values about the topic. So, do you want to quit smoking? What are your thoughts about quitting or reducing your smoking? Do you know that smoking increases your risk for chronic illnesses such as cancer and heart disease? Well, most people are going to say yes to that, right? So you do want to just kind of ask an open question. What do you know? What do you know already about the health risk of smoking? And in the end, open-ended questions are going to build that rapport, right? Because you're encouraging more of an interaction between patient and clinician. It actually will increase the accuracy, right? You get more information and a greater understanding. It will decrease answer bias. So many times patients are saying nope, yes, and they will just say whatever they need to say to continue the visit with you. Open-ended questions does promote autonomy and extends the conversation, which is what we want. The goal in any motivational interviewing encounter is to use more open than closed-ended questions. So closed-ended questions are important as well when you have to stop time or stop the visit. So I'm not trying to say to not ask any closed-ended questions, but just that make sure that it's a little imbalanced towards open-ended. Okay, affirmation statements. Affirmations are really important because they allow you to demonstrate to the patient that you are recognizing the patient's strength and you are affirming their demoralizations or their concerns. You are, by using affirmations, promoting the patient appreciation and understanding and facilitating patient acceptance. By giving affirmations, you're supporting their self-efficacy and enhancing the rapport between you and the patient. The thing to remember is that affirmations need to be closely tied to the patient's values. So you can't just jump out and give an affirmation not too quickly, but you do want to have a sense of what their values are. Understand too that an affirmation you give to person X may be very different for that same affirmation to person Y, because the two people may value different things. So some tips with affirmations: share something you appreciate about the person. I really appreciate that you're working hard on this with me today. I really appreciate you taking the time to talk to me today. Notice their efforts to change, notice their values. You really want to be the best mom. You want to be here for your grandkids, and that's why you're thinking about making a big change with your smoking. Notice the things that are positive about them. Affirming is not the same thing as agreeing with their ideas or approving their choices, right? So you're really reflecting back the patient's values. And I personally would avoid the I statements. Instead of saying, I'm really proud of you, and say something like, you have a lot to be proud of. This is something that you really want to do, because that's much more reflective of what the patient wants to do, and that's what we want to elicit. Okay, reflective statements. So when we're talking with folks, there are many ways where there's potential for miscommunication. So what the speaker means is different from the words the speaker says. What the speaker says can be different from the words the listener hears. And what the listener hears can be different from what the listener thinks the speaker means. And what the listener thinks the speaker means can be different from what the speaker means, right? So I know that I went through that really quickly, but it is worthwhile to think about all the areas where there can be miscommunication. And because of that, reflective statements really help us check in on what we think the patient or the speaker is saying. Reflective statements essentially hypothesize and check in on the speaker's meaning and elicit more information from them. So essentially that goal, by doing that, we're letting the patient know that we're listening and we're trying to understand. It limits questions because we're making statements. We're letting the patient guide the conversation. And it allows us to capture the change talk that the patient is having if we're reflecting that. It allows us to hypothesize instead of asking questions. We are hypothesizing what the patient means. And it allows us to affirm and validate the patient. So lots of great goals of reflective listening, all of which are going to help us elicit and evoke from the patient their own values and understanding. Reflections is one of the harder skills in motivational interviewing. When you first learn this, it may be good to just start off by saying, it seems like you are having a problem. It sounds like you are feeling. And then in time, you want to cut off that "it sounds like" and just make a statement. Like, you're not ready to, you're having a problem. You've been working really hard. Actually, that's an affirmation, right? But an affirmation can be a reflection. So really kind of making that reflection. And even if we're wrong in our hypothesis and our reflection, well, that's important because the patient will correct us, right? So there are a type of reflection statements. They range from content to feeling. Content reflections are really a simple restatement of the statement the patient said. A more complex reflection is reflecting what we think the patient said, but hasn't really said, kind of reading in between the lines. And then a bigger reflection is reflecting feelings. So, an example, I am sick and tired of people always telling me what to do. I mean, really, what do people get off thinking that they have the right to say that? What would be a content reflection? People are always telling you what to do. What would be a meaning reflection? You can decide on your own what to do. And finally, a feeling reflection, you've had enough already. So you can tell if by us reflecting, the patient is going to continue the conversation. When they hear us say those statements, they're going to be like, yeah, you understand what I'm talking about, and let me tell you more. And that's exactly what we want to do. That's the point of the reflection, to extend the conversation. Okay. Recognizing and promoting change talk. So when you hear certain statements, you want to reflect those certain statements. And those certain statements are what we call change talk. Change talk is defined as desire language, ability language, reasons language, or needs. So if you hear someone say, I want to change because I think I can do it, because my reasons to do it is because, and I really need to change. When you hear that, you want to reflect those statements. And why is that important? Well, because the more clients express their commitment to change and they hear it, the more likely they are going to make that change. But on the other hand, if we reflect the disadvantages of change or the status quo, the continued behavior, the more committed they are to sustaining that status quo behavior. So we have to tip the scale by eliciting and reflecting the change talk. So this is a kind of an intermediate skill where when we're hearing a patient talk, we do want to acknowledge the sustained talk, but we really want to reflect strategically the change talk. And those are the desires, abilities, reasons, and needs to stay the same, all within an atmosphere of compassion and autonomy for the patient. So identifying change talk, if we had someone say, or a patient say, sometimes I get scared about my smoking, but that just makes me feel anxious and makes me want to smoke. I know my family doesn't want me to smoke, but thankfully they have stopped bugging me these days. I'm feeling good, except for some fatigue these days. Can you ask yourself, where's the change talk here? So here is the change talk highlighted in green. Sometimes I get scared about my smoking. I know my family doesn't want me to smoke. And some reasons I have some fatigue these days. And if that's the change talk, then how would you reflect this statement? Okay, so I don't give you examples here, but you can think about that on your own. What would you reflect in response? Okay, so just in general, when you hear the change talk, we want to be all ears and explore or ask more open-ended questions. So say, tell me more about your fatigue. What did you mean by that your family is supporting you? You want to affirm. Sounds like you've been thinking about this a lot. Sounds like the fatigue is really bothering you and you want to do something about it. Essentially, reflect, reflect, reflect. And then, of course, summarize. All right, so speaking of summarize, what is that? Summarize really are strategic because they help the other person, the patient, recall what you've talked about and also reflect upon what was said. Giving summary statements helps the patient think of new ideas as you are reflecting back to them what they've said. It helps you to plan next steps for the patient and for the patient to think about next steps as well. And it also helps you as the clinician understand the patient. So in summary, what you want to do for a summary is affirm, thank you for sharing this information. Thank you for talking with me. It sounds like, you've been thinking about your smoking. Summarize the ambivalence. There are some good things about your smoking, which you've mentioned, but on the other hand, there is some not so good things. Summarize the importance. You really are thinking about this a lot, but ultimately you feel like this is important to change because of you want to be able to spend time with your grandson. Summarize their strength and confidence. You're really feeling kind of middle of the road about your confidence, but we talked about how we are here to help support you, and hopefully that can increase your confidence. And then guess at next steps and elicit feedback. So giving these things, the summary, where do you want to go from here? So often I'll just ask a question. What would you like to do? Did I summarize all that correctly? Is another question to elicit some feedback. Okay, so I know that was pretty quick, but we're gonna jump into some MI consistent tobacco cessation strategies. So one that's relatively easy to conduct is what we call decisional balance. So this really kind of allows the patient to see the pros and cons of a behavior. So often I may start off with the benefits of the status quo, the benefits of smoking, and have the patient talk about that briefly. And then I go into what are the downsides of the cost of smoking. And then from there, you go on to the benefits of changing, benefits of quitting, and the downside, the negative side effects of quitting. So once the patient sees all four things, you want to reflect on the change talk. So reflecting on, of really the change talk here. So it kind of helps you, the physician or clinician, to kind of understand where the patient is with their pros and cons of the behavior. Sometimes we like to write these out or have the patient write them out and give it to them. And that's kind of helpful for the patient to kind of see like, oh, I see why I'm ambivalent. There are some good reasons for staying the same. And there are some good reasons for changing as well. Another strategy is to use rulers, 0 to 10 point scale. We always ask about both motivation or the importance of changing as well as the confidence, the skill to change. So the way you do this is how important is it for you right now to change on a scale of 0 to 10? What number would you give yourself? If you want to define 0 to 10, 0 is not at all important, 10 is very important. And once they give you a number, you ask, why are you there and not at a lower number? And so by doing that, you're having the patient argue for why the behavior is so important. And then what you can do after that is ask, well, what would need to happen to raise your number to a little bit higher? So I always go, if they said they were a 5, what would happen to get that level importance to a 6? And this, likewise, you're going to do the same thing with confidence. How confident are you to make this change right now on a scale of 0 to 10, 0 being not at all confident, 10 being very confident? What number would you give yourself? Why are you a 5 and not like a 3 or 4? And then what would you need to happen to make that 5 to a 6? So by asking these kinds of evocative questions in this format kind of allows you to elicit some change talk from the patient. And you'll have to make sure to reflect on what they're saying. Okay. Also important is to understand the difference between sustained talk versus resistance. Sustained talk is really about the behavior, smoking in this case. Resistance is about the relationship, relationship with the patient. You don't understand how hard it is for me versus I really want to quit smoking. That's the target behavior. The good news is that when you hear this type of language coming from a patient, highly responsive to your communication styles. So remember, you're in my spirit and implement that, right? Partnership, collaboration, autonomy, compassion. So when you hear that type of language, you do want to roll with it, reflect, use simple reflections, acknowledge the feelings, accept responsibility on your part if there was some resistance. You may have pushed too hard, you might have criticized, didn't know it. Go back to open-ended questions, understand their perspective. You can, if you'd like strategically, to shift focus, reframe, and if this always works, emphasize personal control and choice. Always works in my experience. Okay, another strategy here is responding to knowledge gaps. Many patients will know things, but they may not know everything. And so you don't want to just give information. You want to ask permission to give advice. So we put the advice in a sandwich. So anytime we're giving information, we always talk about EPE or elicit, provide, elicit. We're going to elicit from them, what is it that you already know? If they don't know something or get something wrong, we're going to ask permission. Mrs. Jones, do you mind if I share some information with you? That's the asking permission. And then hopefully they'll say yes, right? And then you're going to provide that information. And then after you provide the information, you're going to elicit from them. This is really important. Elicit from them, what is your understanding of the information? What did you get from this? What's the most important thing you heard from that? So EPE with a little asking permission in between there is really important. By doing this, you are definitely implementing in my spirit and patient-centered counseling. Okay, so now as we end here, putting it all together on lung cancer screening, these are just some of my thoughts about how why we should be using motivational interviewing, particularly in a lung cancer screening population. Well, as we've said before, this population is interested in quitting, right? The majority of them are interested in quitting, so definitely they may be primed to having the conversation. They may already be concerned about their health since they're coming in for a lung cancer screen test, right? So great to kind of have that conversation. These folks are likely going to be older, 50, age 50 with new guidelines and older, and may have some other medical comorbidities. So smoking is not just only affecting their lungs, but could be affecting other areas, other medical comorbidities as well. These patients may not actively be seeking smoking cessation treatment, so it's a really great opportunity to at least provide, using EPE, right, information for tobacco treatment to this population. This population may be what may be considered the hardcore smokers. It's possible that they've tried to quit before and haven't been successful, and they just haven't run into you, who's really good at motivational interviewing and can kind of work with them, work with their ambivalence, right? And so this is a new opportunity for them to do that, to have that experience. This patient population, because they are hardcore smokers or older, they may have very unique beliefs regarding the harms of smoking, the benefits of quitting, or their ability to quit. So using patient-centered counseling strategies is a great way to kind of provide that information with permission, right? Provide that information to this patient population. There's a lot of emotion in this patient population too, as they are dealing with the stigma of smoking, as well as the stigma of potential lung cancer there. So a lot of great opportunity to be reflecting on emotions. And this patient population, they may be very more likely to value physician opinion and interaction compared to others, and they may want to know, what is it that you advise for me to do? But it's important for us to let them understand that this is really about their choice with regards to smoking cessation, but that we are here for them. some strategies, some continued other strategies. We want to position lung cancer screening and smoking cessation behavior change as their choice, which I've just said. It's really, 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 really important to do that in this context. We do want to acknowledge and affirm the difficulties of quitting, again, using your patient-centered motivational interviewing counseling strategy skill set. Do you want to support and increase their confidence to quit, provide treatment resources and refer? Personalize the information, assess their values, their medical information, and treat all smokers, not just those who are ready to quit. Right? We do want to have some patient-centered approaches here, but I just want to mention that opt-out practices are a growing trend and have been effective in increasing reach. And often if we're using opt-out approaches, we definitely have to be very aware of our MI spirit, patient-centered counseling approaches, because folks may not understand why do I have to talk to you, and relaying that this is your choice. We can stop if you'd like. Is using those MI skills is really important if your clinic is doing opt-out. Some additional strategies here: repeat contact and repeat information about smoking cessation resources is really, really important. And this can be done in the shared decision-making process with the physician. When you're giving feedback and information, also important when you're giving the scan feedback, or it can be repeated in letters home about tobacco treatment. And it's also really important to suggest to discuss at the next visit or connect to tobacco treatment providers or other evidence-based treatment. So it's really important to have this conversation about smoking, not just at the first visit, but in the letters and the feedback and the repeated visits. Really important. Also, I want to just say that everyone who interacts with the patient should be mindful about their impact on the patient's motivation. So I'm not just talking about the clinician, but the person who checks you in, the person who escorts them to the back room, CT folks. If the patient is perceiving negative judgment or stigma, that may prevent them from returning to another screen or encourage resistance at the next visit. So really important that the whole team understands some of these essential basic motivational interviewing or patient-centered counseling approaches. Okay, so almost out of time here. Just want to give a plug out to this book, Motivational Interviewing Skills. It's a workbook and that you can buy and do some practice. This other book, Motivational Interviewing in Healthcare, is a great read, but really how to learn, keep attending workshops like this, read, learn more, practice, and audio tape yourself, and try something, right? Try something at your next visit and really observe how does the patient react. So your next visit with someone, try the EPE method and, kind of figure out like, oh, that was interesting. How did the patient react? Find a partner, get feedback and supervision, record your work. And then ultimately, I think it's really important to train others because as we heard, we believe what we hear ourselves say. So the more that we are able to teach and provide to others, the more we're going to practice it as well. Okay, so just some resources. The Motivational Interviewing Network of Trainers, this is their website. Lots of great videos that you can look at there. Of course, Miller and Rolnick, who are their founders of Motivational Interviewing, this is their latest book that came out in 2013. And of course, this is just the reference for that workbook for those who really want to get into depth there. Okay, so some concluding thoughts as we stop today is really would love for you all to think about what's something new that you've learned today, if anything, and what, if anything, will you start to implement or practice in your work. And with that, I think we are out of time, but I'm happy to take questions by email. This is my email address, and I look forward to hearing from you soon. Thank you so much, and good luck with your motivational interviewing skills.
And thank you all. Thank you, Dr. Hayes, for being so game and nimble in trying to work through the technical issues, and to our audience for being so patient and understanding. We truly appreciate it. A couple of resources I wanted to mention here in closing. The LUCA National Training Network has a terrific insurance coverage guide available on their website. We will be sharing the slides, so you'll have a hyperlink to it, and I'll make sure to include the direct link as well. And American Lung Association has a billing guide for tobacco screening and cessation as well. And I know that the questions around coverage and billing are ones that are ever present, so hopefully those two resources will be helpful. Just to mention a couple of GoTo Foundation resources. I have shared these before in previous webinars, so I won't go into a great deal of detail. But of course, we do have our patient education video that can be used in to prepare for a shared decision-making conversation. It can be downloaded from our website. It's available in Spanish and simple Chinese as well. We have a range of brochures and fact sheets, our Why Quit Now brochure, a lung nodule fact sheet that is very, very popular, and our regular lung cancer screening living rooms that are available that are streamed live through Facebook and YouTube, and then they are housed on our website. I will also want to mention our Centers of Excellence Summit. This year it will be virtual again. The dates are being finalized, but it is planned for the middle of October. For those who participated in last year's summit, all of those presentations are still up on our conference web platform. So you can go back and view any of them, any of the on-demand sessions or the live sessions that were recorded. Those will be there until, I believe, October. We also will be moving those over to the GoTo website for broader access at some point, but that planning is still underway. You also will receive a brief evaluation survey from me by email. Do take a couple of moments to complete it. and again, I appreciate your patience with the technical glitches, but share your feedback to guide our future efforts, especially around other topics you'd like to hear about and any speaker ideas that you have. And as always, reach out to us anytime at screening@gotofoundation.org. I do want to extend our sincere thanks to our sponsors of the Excellence in Screening and Care program: AstraZeneca, Bristol Myers Squibb, Bristol Myers Squibb Foundation, Genentech, Lilly Oncology, Pfizer, and Takeda. And that does it for us today. Thank you all so much for your time and attention. Be well, everyone.